Diabetes insipidus, DI, stands as a paradox within the realm of metabolic disorders. Unlike its more commonly recognized counterpart, diabetes mellitus, which involves issues with blood sugar regulation, DI manifests as a condition marked by excessive urination and thirst, stemming from an inability to regulate fluid balance within the body. Despite its less prevalent status, understanding DI is crucial for healthcare professionals and patients alike, as it presents unique challenges in diagnosis and management. At its core, diabetes insipidus disrupts the body's ability to maintain proper hydration levels, leading to profound consequences if left untreated. This condition, often misunderstood and misdiagnosed, encompasses various subtypes, each with its distinct etiology and clinical presentation. Central diabetes insipidus (CDI) arises from insufficient production or release of antidiuretic hormone, ADH, by the hypothalamus or pituitary gland, whereas nephrogenic diabetes insipidus (NDI) results from the kidney's inability to respond to ADH. Additionally, gestational diabetes insipidus may occur transiently during pregnancy, and primary polydipsia involves excessive fluid intake, leading to similar symptoms. Recognizing the signs and symptoms of DI requires a nuanced understanding, as they often overlap with other conditions or may be mistaken for normal variations in urinary habits. Polyuria, excessive thirst, polydipsia, and nocturia represent hallmark features of DI, ultimately leading to dehydration and electrolyte imbalances if not adequately addressed. In this article, we embark on a comprehensive exploration of diabetes insipidus, shedding light on its pathophysiology, diagnostic approaches, treatment modalities, and potential complications. By delving into the intricacies of this lesser-known disorder, we aim to provide clarity and insight into managing DI effectively, thereby improving outcomes and enhancing the quality of life for those affected by this condition. 2. Understanding diabetes. Insipidus. Diabetes. Insipidus DI is a heterogeneous disorder characterized by the excretion of large volumes of diluted urine, leading to excessive thirst and dehydration. Despite its rarity compared to diabetes mellitus, understanding the underlying mechanisms and subtypes of D is paramount for accurate diagnosis and targeted management. A. What is diabetes insipidus? Diabetes insipidus derives its name from the Latin term insipidus, meaning tasteless or odorless, reflecting the dilute nature of the urine produced in this condition. Unlike diabetes mellitus, which involves abnormalities in insulin secretion or action, DI primarily affects the regulation of water balance in the body, specifically the reabsorption of water by the kidneys. B types of DMTR1. Central diabetes insipidus, CDI. CDI results from a deficiency in the synthesis, secretion, or action of antidiuretic hormone, ADH, also known as vasopressin. This hormone is produced in the hypothalamus and released from the posterior pituitary gland, where it acts on the kidneys to promote water reabsorption. 2. Nephrogenic diabetes, insipidus, NDI. NDI occurs when the kidneys fail to respond adequately to circulating ADH, despite normal production and secretion by the hypothalamus and pituitary gland. This resistance to ADH action impairs the kidney's ability to concentrate urine, leading to excessive fluid loss. 3. Gestational diabetes. Insipidus. Gestational DI is a transient form of the condition that may develop during pregnancy due to increased metabolic demands and alterations in hormone levels. It typically resolves postpartum, but can pose risks to maternal and fetal health if left untreated. 4. Primary polydipsia, also known as psychogenic polydipsia. Primary polydipsia involves excessive fluid intake, often secondary to psychiatric or behavioral disorders, leading to symptoms mimicking DI. Understanding the diverse etiologies and presentations of DI lays the foundation for accurate diagnosis and tailored management strategies, ensuring optimal outcomes for affected individuals. 3. Diagnosis of diabetes insipidus. Accurate diagnosis of diabetes insipidus (DI) relies on a comprehensive evaluation encompassing clinical assessment, laboratory testing, and imaging studies to differentiate between the various subtypes and identify underlying causes. A clinical evaluation and history. The initial step in diagnosing DI involves a thorough medical history and physical examination to identify symptoms such as polyuria, polydipsia, nocturia, and signs of dehydration. Patients may also provide information regarding potential triggers or underlying conditions that could contribute to DI, such as head trauma, neurosurgery, or medication use. B. Laboratory tests. 1. Urine output measurement. Quantifying urine output over a specified period, typically 24 hours, helps assess the severity of polyuria and guides further diagnostic investigations. 2. Serum and urine osmolality. Measurement of serum and urine. Osmolality provides valuable insights into the body's ability to concentrate urine. In DI, urine osmolality remains low despite serum hyperosmolality, reflecting impaired water reabsorption. 3. Water deprivation test. This dynamic test involves withholding fluids while monitoring changes in urine output and osmolality over time. In individuals with DI, urine output remains high, and urine osmolality fails to increase significantly despite dehydration. 4. Desmopressin stimulation test. Administering synthetic ADH, desmopressin, and monitoring urinary concentration response helps differentiate between central and nephrogenic forms of DI, with an attenuated response observed in nephrogenic DI. See imaging studies. 1. Magnetic resonance imaging, MRI. Brain imaging may be indicated to assess for structural abnormalities or lesions within the hypothalamus or pituitary gland, particularly in cases of suspected central DI. 2. Computed tomography, CT. Renal imaging may be performed to evaluate for structural abnormalities or signs of chronic kidney disease in individuals with nephrogenic DI. By integrating clinical findings with laboratory and imaging data, healthcare providers can establish a definitive diagnosis of DI and formulate an appropriate management plan tailored to the underlying etiology and subtype. IV treatment and management. Effective management of diabetes insipidus, DI, aims to alleviate symptoms, restore fluid balance, and prevent complications through a combination of pharmacological interventions, lifestyle modifications, and regular monitoring. A. Treatment goals. The primary objectives of DI management include 1. Replacing deficient antidiuretic hormone, ADH, or enhancing its action to promote water reabsorption. 2. Addressing excessive fluid loss through polyuria to prevent dehydration and electrolyte imbalances, identifying and treating underlying causes or contributing factors, such as central nervous system disorders, or medications that may exacerbate DI. Pharmacological interventions. Desmopressin, DDAVP. Desmopressin, a synthetic analog of ADH, is the cornerstone of central DI treatment. Administered orally, intranasally, or subcutaneously, desmopressin helps restore water balance by enhancing renal water reabsorption and reducing urinary output. Thiazide diuretics. In nephrogenic DI, thiazide diuretics such as hydrochlorothiazide may be prescribed to enhance renal tubular water reabsorption by inducing mild volume depletion and paradoxically reducing urine output. Non-steroidal anti-inflammatory drugs, NSAIDs, NSAIDs, particularly indomethacin, may be beneficial in select cases of nephrogenic DI by reducing renal prostaglandin synthesis and enhancing responsiveness to ADH. Lifestyle modifications. Fluid intake regulation. Patients with DI should maintain adequate hydration while avoiding excessive fluid intake to minimize polyuria and nocturia. Dietary adjustments. Consuming a balanced diet with moderate sodium intake can help prevent electrolyte imbalances and reduce the risk of dehydration. Monitoring and follow-up. Regular monitoring of fluid intake, urine output, and electrolyte levels is essential to assess treatment efficacy, adjust medication dosages as needed, and identify potential complications. By implementing a comprehensive treatment approach tailored to the underlying subtype and individual needs, healthcare providers can effectively manage DI and improve patient outcomes while promoting optimal fluid balance and quality of life. Complications and prognosis. Despite advancements in diagnosis and management, diabetes insipidus, DI, can lead to various complications if left untreated or inadequately controlled, impacting both short-term well-being and long-term prognosis. Potential complications of untreated DI. Dehydration. Excessive fluid loss through polyuria can result in dehydration, leading to weakness, dizziness, tachycardia, and hypotension. Severe dehydration may progress to hypovolemic shock, a life-threatening condition requiring prompt medical intervention. Electrolyte imbalances. Prolonged polyuria can disrupt electrolyte balance, particularly sodium and potassium levels, predisposing individuals to hyponatremia or hypernatremia, hypokalemia, and metabolic acidosis. Renal impairment. Chronic dehydration and electrolyte disturbances may contribute to renal dysfunction, including impaired renal concentrating ability, chronic kidney disease, and nephrogenic DI. Neurological complications. Severe dehydration and electrolyte imbalances can lead to neurological symptoms such as confusion, lethargy, seizures, and coma, necessitating urgent medical attention. Long-term outlook and prognosis with proper management. With timely diagnosis and appropriate management, individuals with DI can achieve good long-term outcomes and quality of life. Treatment strategies to restore fluid balance, replenish deficient ADH, and address underlying causes can effectively alleviate symptoms and prevent complications. The prognosis largely depends on the subtype and underlying etiology of DI. Central DI typically responds well to desmopressin therapy, with most patients experiencing significant symptom improvement and minimal adverse effects. Nephrogenic DI may pose challenges in management, but optimization of fluid intake, electrolyte monitoring, and pharmacological interventions can help mitigate symptoms and reduce the risk of complications. Regular follow-up and monitoring are essential to assess treatment efficacy, adjust medication dosages as needed, and address any emerging complications, ensuring optimal outcomes and quality of life for individuals living with DI. Current research and future directions. Ongoing research into diabetes. Insipidus, DI, continues to advance our understanding of the underlying mechanisms, refine diagnostic approaches, and explore novel treatment modalities, aiming to improve outcomes and quality of life for affected individuals. Ongoing studies and areas of interest in DI research. Genetic predisposition. Investigating the genetic basis of DI, including mutations affecting genes involved in ADH synthesis, secretion, and renal responsiveness, offers insights into familial forms of the condition and potential targets for therapeutic intervention. Neuroendocrine regulation. Understanding the intricate interplay between hypothalamic pituitary function, ADH secretion, and renal water handling provides opportunities to identify critical regulatory pathways disrupted in DI and develop targeted therapies. Novel diagnostic tools. Advances in imaging techniques, biomarker discovery, and genetic testing hold promise for enhancing the accuracy and efficiency of DI diagnosis, enabling early intervention and personalized treatment strategies. Pharmacological innovations. Exploring alternative pharmacological agents, including vasopressin receptor agonists, aquaporin modulators, and gene therapy approaches, may offer alternative treatment options for refractory cases of DI or those with limited response to conventional therapies. Potential breakthroughs and advancements in treatment. Precision medicine, tailoring treatment approaches based on individual genetic profiles, underlying etiology, and responsiveness to therapy, holds the potential for optimizing treatment outcomes and minimizing adverse effects in patients with DI. Targeted therapies, targeting specific molecular pathways involved in ADH synthesis, secretion, or renal action, offers opportunities for developing more effective and well-tolerated treatments for different subtypes of DI. Patient-centered care, emphasizing patient education, self-management strategies, and shared decision-making empowers individuals living with DI to participate in their care actively, optimize treatment adherence, and improve overall quality of life. Despite DI's challenges, ongoing research offers hope for continued advancements in diagnosis, treatment, and patient care, paving the way for better outcomes and enhanced well-being for individuals affected by this complex condition. In conclusion, diabetes insipidus, DI, presents a complex and often misunderstood clinical entity characterized by excessive thirst, polyuria, and impaired fluid balance. Despite its rarity compared to diabetes mellitus, DI poses significant challenges in diagnosis, management, and long-term care, necessitating a multidisciplinary approach and ongoing research efforts. Through this comprehensive exploration of DI, we have delved into its diverse subtypes, etiologies, diagnostic modalities, and treatment strategies. From central DI resulting from hypothalamic pituitary dysfunction to nephrogenic DI stemming from renal insensitivity to antidiuretic hormone. Each subtype requires tailored approaches to address underlying pathophysiology and alleviate symptoms effectively. Diagnostic challenges in DI underscore the importance of a systematic evaluation, incorporating clinical history, laboratory tests, and imaging studies to differentiate between various subtypes and identify underlying causes. Once diagnosed, management strategies aim to restore fluid balance, replenish deficient antidiuretic hormones, and address contributing factors, minimizing symptoms and preventing complications. Looking ahead, ongoing research into the genetic, neuroendocrine, and pharmacological aspects of DI holds promise for further elucidating its pathophysiology and identifying novel therapeutic targets. Precision medicine approaches, coupled with patient-centered care and shared decision-making, offer opportunities for optimizing treatment outcomes and enhancing the quality of life for individuals living with DI. As we expand our understanding of this complex disorder, collaboration among healthcare providers, researchers, and patient advocates remains paramount in advancing diagnostic accuracy, treatment efficacy, and overall patient care. By raising awareness, promoting education, and advocating for continued research, we can strive towards better outcomes and improved quality of life for individuals affected by diabetes insipidus.